There we go.
Great.
Wonderful. There he is. Dr. Easaw is a professor in the Division of Medical Oncology at the Cross Cancer Institute in Edmonton, Alberta. He is board certified in internal medicine and medical oncology. He is actively involved in both patient care and clinical research. His research interests include metabolomics, database design, clinical informatics, and the introduction of technology into clinic. He is a recent recipient of awards in both teaching and research excellence. I've actually had the pleasure of working with Dr. Easaw on a variety of collaborative projects over the years, and we've had him as a presenter at healthcare professional symposiums and information days that we used to have in the past. So lovely to collaborate with you again, Dr. Easaw.
Thank you.
Dr. Easaw will update our current understanding of glioblastoma today. Specifically, he will focus on current management and promising future therapies. He's also going to review significant updates in pathology that have given us a better understanding of overall survival and response to treatment. And so if you have questions for Dr. Easaw, we will take those up at the end of his presentation. And you should be able to share your screen now, Dr. Easaw. Will it let you? The big green button?
Can you see my screen?
No, not yet.
Okay. Share screen. Can you see it now?
Coming up. Yeah, it's coming up. Yeah, can see it now. Perfect.
Great.
So the floor is yours, so to speak. I will mute myself and take my video off, but if you need anything, just give me a holler.
Great. Thank you. Hi, everyone. Thank you for joining me. It's a great pleasure for me to speak with you today. This is a topic that I'm very passionate about. And so I'm going to nerd out on you in a little bit. I'm going to teach you how to read an MRI scan. And there's a bunch of stuff that I'm excited to show you. So the title of my talk is Care of Patients with Glioblastoma, Current Opportunities and Challenges. I have three goals today. What is a glioblastoma? I'm going to refer to it as a GBM. And I'm gonna dive deep on pathology, radiology, and the molecular markers. There are some unique challenges that make treating this cancer difficult at times. Some of you may have heard about some of the new advances in treatments for other cancers, immunotherapy being one of them. And I want to talk to you about where the challenges are in bringing these new treatments in for patients with glioblastoma. And then finally, I want to talk to you about the new treatment options that are on the horizon and really with a focus on new clinical trials. So this is a picture of a group of cells. This started as a single cell, for example, right here. And then 24 hours later, it's this. This is a glioblastoma that has grown in culture. There are very few cancers that have this capacity to grow as fast as this kind of tumor does. So this is just 24 hours, an electron microscopic picture. So just to kind of set the stage of what we're up against here. Now this is an MRI scan. Now, if there are other physicians on the line who look at MRI scans, you'll be able to see immediately that this right here is a tumor, and it's classic for a glioblastoma, which I'm going to go through later. But this is an MRI scan of someone lying on their back. So this is the back of the head, the nose would be here, the right ear would be here, and the left ear would be here. So you're looking from their feet up. Now, looking at this MRI scan, you can tell immediately that this patient is in trouble. Here's the tumor right here. It's got this mottled appearance, dark and bright, and it overlies the right ventricle. This is the left ventricle here, and you can see that the right ventricle is blocked. You see these nice sulci and gyri on the left. They're gone on the right, which tells you that there's pressure on this side of the brain. And if you look, you can see that the brain seems like it's squished over a little bit, and that's because of the swelling pushing the brain over. And this ventricle right here, which is nice and open, is closed, or is closing. So I'm going to return back to this patient of mine later on in my talk, but that is the classic way to read an MRI scan. Left, right, that's up. That's a glioblastoma. GBM is the most common type of primary brain tumor. So what do I mean by a primary brain tumor? So a patient can have brain tumors that are either primary or secondary. So a secondary is someone who has let's say a colon cancer or a breast cancer, and that cancer spreads from the colon cancer, for example, to the brain. But a primary brain cancer is one that starts in the brain. So GBM is the most common type of primary brain tumor, and it accounts for just under half of all the primary brain tumors that we see. About 1,200 Canadians will be affected this year, and it is the most aggressive of all the brain cancers. This is a picture taken from some lab work that I've done, and the green pictures here show a neuron, and the red shows glial cells. Neurons are the thinking cells, the cells that allow me to move my hand like this. Though that is all controlled by neurons. Glial cells are nanny cells. Their job is to take care of the neurons, to create an environment where the neurons can function properly. When a glial cell becomes malignant, we call it a glioma. And the most aggressive of the gliomas is a glioblastoma. So the glioblastomas derive from these glial cells. Now, you may have heard terms like stage 2, stage 3, stage 4 cancer. We don't stage gliomas. We grade them. Stage refers to a cancer like a colon cancer, which I also treat, that can start in the colon, spread to a lymph node, and then, say, metastasize to the liver. Gliomas don't metastasize. They don't spread outside of the central nervous system. So we don't stage them, we only grade them. And the grade refers to what it looks like under the microscope. The more aggressive the tumor, the higher the grade. And we grade gliomas from 1 to 4. Grade 1 tumors are extremely slow growing, and we almost never see them in our clinic. We see grade 2 tumors, grade 3 tumor patients, and then grade 4 patients. Patients with grade 2 tumors have a median survival of 13 to 14 years. And grade 3 tumors patients have median survivals varying from 3 to 14 years, depending on the molecular markers. But what we're talking about today are patients with grade 4 tumors, glioblastoma, with no treatment, no surgery, no chemo, no radiation. The median survival can be 2.5 months. But with chemotherapy and radiation, that median survival, that's what MS stands for, is 15 months. The median survival is probably better than that across the country now, more like 18 months on average, because we've gotten better, but this is based on the published literature. So if you were to look at the median age, this is looking at US data. In the United States, the median age is 64. Here in Edmonton, the median age is 58. And before I got recruited to Edmonton, I was in Calgary, and the median age in Calgary is 55 because it's a younger patient population. So this is predominantly a cancer of younger people. We talked about how glioblastoma grows quickly, and I want to bring you back to this MRI scan that I showed you at the very beginning. This is the MRI scan I showed you. And here's the glioblastoma right here. I offered this patient treatment and he declined. His preference was to not pursue any treatment. And this is his MRI scan when I saw him in the emergency department 8 weeks later. And you can tell that it's much worse. Here's the original glioblastoma that has now spread to the other side of the brain. That pressure that you see here is now extending all the way pretty much through most of the brain, through about 3/4 of it. You can tell that the brain is pushed over even more compared to here. And these ventricles here, the left and the right ventricles, look bigger than they do on this side. And that's because the cancer has blocked them. And the fluid that normally flows through the ventricles is trapped, and it's starting to swell. This patient died shortly after this MRI scan was taken, and it gives you a sense of the rate of growth that can occur in this patient population. One of the other important things about this cancer is that it's one of the most vascular tumors. And what I mean by that, it means it has one of the highest blood flows going to a cancer. So if you, for example, could pretend that this was a glioblastoma or a GBM tumor cell in the brain, it needs to get blood to itself so that from the brain, so that it can get the oxygen and the nutrients it needs. And it sends out these factors called chemoattractants that divert the blood flow to the tumor to feed it the oxygen, the nutrients it needs. And as you can tell, the blood, these blood vessels that take blood to the tumor allow the cancer cells to then spread elsewhere. So this is a vascularized tumor, and we call this whole process angiogenesis. One of the unique features about glioblastoma is that its total focus is on growing. And so much so that it diverts the blood flow from inside the tumor to the outside. So it's willing to sacrifice the tumor in the middle. It allows it to die so that the blood vessels that were feeding it now are directed out. And that is one of the defining features of a glioblastoma, and we call that necrosis. Here's another picture of a of an MRI scan with a glioblastoma, and you can see that it's bright on the outside and dark on the inside. That dark area is the necrotic area. This is where the tumor has taken the blood flow and diverted it to the edge so that it can continue to grow. And this area in the middle is sacrificed, and it's dead, or what we call necrotic. Classic feature of this cancer. One of the other things that is common, and for those of you that are patients or caregivers of patients, you may have heard your physician talking about how this tumor can extend tentacles into the adjacent brain. This is some work from our own lab, and what you see here is a tumor and another patient with a tumor. And this is the edge of the tumor according to the MRI scan. And you can see these extensions of tumor, and these are the tentacles that I was talking about. It sends out these tentacles into the brain, and that's how it invades. So you see that these tumors, they grow quickly, they invade with these tentacles, and they're highly vascularized. The most important challenge that we face in treating patients with this cancer is something called the blood-brain barrier, or the BBB. Some of you may have heard about this. It prevents drugs from entering the brain. Now, we have the blood-brain barrier because it defends us. If you have an infection, and if that infection gets into the blood, it doesn't typically go into the brain because the brain has this wall or this barrier that defends itself. But that same wall prevents drugs going into the brain. So we have all these amazing chemo drugs, immunotherapy drugs that work below the brain because there's no blood-brain barrier, but a lot of them cannot get into the brain because of this. So let me show you what I mean. So I am no artist, and you're going to tell that right away. This is an example of a blood vessel, and these black circles are chemo drugs. And what would happen is you take chemo, in this case temozolomide, for example, it goes into the stomach, and then it goes into the blood, and that's how it goes into the brain. And so this, for example, could be temozolomide. And what would happen is it would go across the blood vessel into the brain, except that in the brain, there's this wall, this blood-brain barrier, that the chemo cannot get past it and cannot get through into the brain. So very few drugs can actually do this. One of the drugs that can is temozolomide. So this is the clinical trial that showed that temozolomide with radiation can improve survival in patients with GBM. And this was a trial where they took patients who had GBM and they randomized them. Half of them got 6 weeks of radiation alone. Half got radiation and temozolomide and then were followed with additional chemotherapy. So you see 6 months of temozolomide, that was the clinical trial. Many of you, those of you who are patients, may be offered 12 months of temozolomide, and that is based on some work that we've done here in Alberta to show that an additional 6 months in some cases can improve survival. Temozolomide is a pill. It crosses the blood-brain barrier, and the way it kills tumor cells is it's an alkylator. And what that means is it takes a methyl group and attaches it to DNA. And when you have a DNA nucleoside that has a methyl group on it, it can't replicate. And so then the cell dies. And so that's how it kills tumors. Now this is nerding out a little bit, but this is the figure is this figure shows the reason why we use temozolomide with radiation. So on the y-axis here, you have survival and over time. And patients who were treated with radiation alone had a median survival of 12.1 months. And then with the addition of chemotherapy, the temozolomide, you can see that that median survival shifted to 14.6 months. And we here in Alberta just use 15 months as the median survival. So what does median survival mean? Median survival means literally if you took a pie and cut it in half the patients won't make it to that number and half live past. So a median survival of 15 months means half don't make it that far, but half live past that. Now, this is a very busy slide, but it shows you the first of the two molecular markers that I want to talk to you about, MGMT. Now, MGMT is a DNA repair enzyme. And if that repair enzyme, the DNA for that, if it's methylated, if the promoter is methylated, to get kind of detailed, patients with this presentation, that's roughly half, will have a median survival that's actually 21.7 months, so nearly 2 years. But if a patient has unmethylated MGMT, nearly the other half, the median survival with the temozolomide is 12.7 months, pretty much the same as the radiation. So you might be asking, well, why do we give temozolomide to everybody, whether they're methylated or they're unmethylated? And the reason is because of this. In the unmethylated patient population, 15% get a benefit from the temozolomide. And we cannot identify who those 15% are. And so what we do is we give temozolomide to everybody because we do not want to miss this patient group that will benefit. So everybody gets the temozolomide, but the patients who do the very best are those who have a methylated MGMT promoter. The second key marker, in addition to MGMT, is IDH. IDH stands for isocitrate dehydrogenase. And when IDH is mutated, specifically IDH1 and IDH2, this predicts who will be our longest survivors. So IDH mutation 1, IDH mutation 2, those patients are associated with our longest survivors. So a patient who has MGMT promoter methylation and IDH mutation, and especially if they have a good resection, those are our patients who have the longest survival. I want to introduce to you kind of a new treatment that some of you may have heard of, some of you may actually be receiving. This is tumor treating fields, or TTF. And this is basically where patients carry a battery pack, and it provides a stimulation to the brain. So these are electrodes on the brain that provide an electrical field pulse. And this is not yet approved in Canada, and the company has run out of compassionate supply. But this is something that will be coming almost certainly this year. It's in the process of getting Health Canada approval. These data showed that when compared to temozolomide alone, the standard of care, and when patients had the TTF, the median survival improved from that 15, 16-month period to 20.9 months. So we are seeing that there are treatments available, and these treatments are in the process of coming and will be Health Canada approved almost certainly this year. But with that said, the majority of patients with this cancer will pass away even within a couple of years of their diagnosis. We have long-term survivors, but a lot of them will not survive. And so this is where the focus in Canada and across the world is, what can we do to improve this? And that comes down to clinical trials. I have reviewed the number of clinical trials on the international clinicaltrials.gov website, and there are over 100 of them, including trials ongoing with TTF. 20% of the trials involve immunotherapy. And so I'm going to talk to you about what immunotherapy is in the context of sort of the next section of the talk, which is to talk about the clinical trials. And I put strategies for immunotherapy at the top because that's what I want to kind of end on. But I want to talk to you about 2 clinical trials that are going on right now. De Novo is a trial that we're running here in Canada, or in Edmonton rather. It is comparison of the standard of care, which is radiation and temozolomide, versus radiation, temozolomide, and enzastorin, which is a protein kinase C inhibitor. And this trial is paused at the moment. And the primary reason why it's paused is the patients have been doing better than expected. So they had to pause the trial to make sure that the statistics make sense and everything really is correct. So we don't know when this trial is going to reopen. But that's one trial that's opened. Another trial that's being run in many centers across Canada is called the AGILE trial for newly diagnosed patients and patients whose cancer has come back. And AGILE stands for the Adaptive Global and Innovative Learning Environment. And basically what the focus of this trial is to evaluate drugs quickly, to determine very quickly, is this drug working or not? The standard time for a clinical trial to go from beginning to the time that the drug is approved is on the order of years, as a minimum a couple of years. What this trial is doing is very quickly assessing a patient's response to a treatment. And they're trying 7 different treatments, which I've listed here, versus the standard of care. And if the drug shows no early promise in terms of a response, the drug is dropped and they move to the next drug, and then they move to the next treatment. And so some of you may be on this trial, some of you may have heard about this trial, but that's kind of the nature of how that trial is working. There is another trial coming forward looking at TTF fields with immunotherapy. And so that's not up and running yet. It won't probably be here maybe until the end of the year. But that's my segue to talk to you about immunotherapy itself. There are 2 kinds of immunotherapy that I want to talk about. The first is checkpoint inhibitors. And so you're gonna see more of my art, for lack of a better word. But most oncologists believe that all of us, get cancer cells every day, but the body is able to clear them. And the body is able to clear them because our immune system can get in there and destroy that cancer cell. But some cells can avoid or evade immune detection and can grow. So the hunter cells in the immune system are called T cells. So their job is to hunt down cancer cells and bacteria. Anything that poses a threat to us, these cells will destroy. Now, the body does not want these T cells to be hunting all the time. And so there are shutoff mechanisms that the body has to turn these cells off. Now they go by fancy terms like CTLA4 and PD1, so that when the body wants to shut the T cell off, it sends something called a ligand, which is something that will bind to this receptor and to this receptor. And when the receptors are bound, the T cell gets turned off. Cancer cells are very smart because many of them will express the ligand that shuts these cells off. So the shutoff signal is not coming from the body, it's coming from the cancer. So that when the cancer cell is in close contact with the T cell, the hunter, it turns it off by virtue of having these ligands on the surface. And what happens is the T cell gets turned off There is no immune cell to clear this cancer cell, and the cancer is allowed to grow. So, what is immunotherapy? Immunotherapy is where we can give a drug or drugs that will block this. It doesn't activate it and turn off the receptor, turn off the cell. It just blocks this receptor and blocks this so that the ligand on the cancer cell can't activate the receptor, can't bind to the receptor. So we have a bunch of immunotherapy drugs, nivolumab, ipilimumab, are drugs that will bind these receptors. Cancer cells can't bind, the T cells can now attack the cancer cell. This has revolutionized cancer treatment, except in the brain. For some reason, the immunotherapy treatments that have been tried so far have not been effective. We're not sure if that drug is actually getting into the brain or not, whether that's a blood-brain barrier problem, or whether the immune cells in the brain are just not able to attack and destroy these cancer cells. The second immunotherapy I wanted to talk to you about is called CAR-T. Some of you may have heard of this, chimeric antigen receptor cells, or CAR-T. Now, the way CAR-T works is that these are T cells that get into the tumor, and but there's not enough of them to get in and kill the cancer. But these T cells are very rare because they are the few that can evade the defenses put up by the cancer cell and get in there. So what CAR-T does, the process is that the tumor will be removed. These very specialized T cells will be extracted and then grown, multiplied. So now you have a whole army of these specialized T cells. They get injected back into the patient, and these things are like homing in on the cancer and are incredible. CAR-T is really only being used in lymphoma or blood cancers right now. We're doing that here in Edmonton. But this technology is being moved into brain cancers. And there is a clinical trial one that I know of in Los Angeles at City of Hope Hospital that is trying CAR-T technology in humans. The challenge with CAR-T is that these T cells are like ultra aggressive, and they can go after the cancer cell, but they can also attack self. They can attack the patient itself. And so when we do CAR-T treatment here in Edmonton, we actually have to have an ICU bed available for them, so that if they get really sick, there's a place that has the capacity to take care of them. So immunotherapy is absolutely the future. It's going to be a thing for brain cancer. It's just going to be a matter of time. So, so I want to end my talk there and return back to the objectives, which were, what is a glioblastoma? We've talked about pathology. We've looked at MRI scans. We've talked about the molecular markers, MGMT promoter methylation and IDH mutation. We've talked about the unique challenges associated with this tumor. It grows quickly, highly vascularized. We talked about the necrosis. We talked about the blood-brain barrier. And finally, we've talked about some of the clinical trials that are coming forward and really put a focus on immunotherapy. Now, I deliberately wanted to stop my talk early and not go the full hour, because what I was really hoping was that we'd have an opportunity to, I'd have an opportunity to answer some of your questions, because for sure, with more than a third of the attendees today being patients, a lot of you might have questions, and I'd be happy to answer them as best as I can, understanding that I don't know your particular situation, but happy to talk to you about what I know.
Perfect. Thank you so much, Dr. Easaw. That was As always, your presentations are just really easy to understand. Love your doodles. They're effective. They're simple but effective. And yes, we did have some questions that came through, so I can read those
Great.
to you. The first one is, do you think GBM is hereditary? And if two members in your family have been taken or have died from a GBM, are there any tests that can be done?
So the answer to question 1 is no, and to question 2 is yes. So question 1, do I think GBM is hereditary for the vast, vast majority of patients? The answer is no. We use the term idiopathic, which means that this arose through bad luck, that the body wasn't able to clear the cancer. There are, however, some cases where there is a genetic risk.
Mhm.
And the most common genetic risk is something called Lynch syndrome. Lynch syndrome, Lynch. And so for the patient who's asking, absolutely, they need to be tested because it is very uncommon for there to be 2 glioblastomas in one family. And what I would do for that patient would be to be asking other questions like, are there other cancers in the family history, particularly something like colon cancer? If there are, those other cancers are on the Lynch syndrome spectrum as well. So absolutely, for that patient, genetic testing is got to be done.
Okay, perfect. Thank you. I'll actually have you can stop sharing your screen if you want.
Oh, sure.
Awesome. Okay, the next question is, my hubby was diagnosed with a grade 2 I'm sorry.
Gemcitabine.
Thank you. Astrocytoma in November 2020. He had a recurrence in February 2022, at which time it was upgraded to a grade 4. We were told, however, that it wasn't a glioblastoma. Do you have any comments on that?
Yeah, so this is a result of the new pathological grading that we have. So almost certainly, if we were to dig into the molecular markers, the tumor is IDH mutated. So a grade 4 IDH mutated tumor is not called a glioblastoma, but it's still a grade 4 tumor, and we treat it like a glioblastoma. So your doc is actually being almost certainly being very precise with their language. That we don't call it a GBM, we call it a grade 4 glioma.
Okay, perfect. Thank you. Excuse me. Are you aware of any research on THC and CBD and its role in shrinking tumors? There have been reports of much better results shrinking brain tumors with THC compared to chemo and radiation.
Gosh, this is such a great question. I'm going to tell you that 1 out of every 5 of my patients is on THC. So it's common. Now, I don't know any physicians that prescribe it because there is no randomized control data. However, so there doesn't appear to be any sort of large randomized data to show benefit. In fact, a paper was just published last week in the Journal of Clinical Oncology, not in brain cancer, but in other solid tumors. I think it was prostate cancer that showed no benefit. It was an actual properly done randomized phase 3 trial. Where I have seen benefit with it is pain control, nausea, appetite stimulation. Now that so many patients are on it, we kind of get this opportunity to look at how patients are doing on it. And I can tell you in my own experience, I'm just not seeing that kind of benefit. I feel like we've treated several hundred since cannabis became legalized, and we haven't seen that kind of benefit. But I don't think any docs would be averse to a patient taking it because it doesn't interact with any of our drugs.
Right. Okay. Thank you for answering that. Another question is, can you please provide any information about a gliosarcoma?
Mm-hmm.
I have been diagnosed with the gliosarcoma and told that it's more aggressive and more rare than glioblastoma.
Yeah, so this is kind of akin to the other question about that IDH mutated grade 4 glioma that's not called a glioblastoma. This is what you've been diagnosed with is a gliosarcoma. It is a more aggressive variant because of the sarcoma component. However, it's more aggressive if nothing is done.
Mhm.
But if it's treated as we do with all glioblastomas, your chances are just as good as anybody else with a glioblastoma, and hopefully the molecular markers are positive, suggesting that you'll do even better.
Mhm.
One of my longest survivors in our practice here has a gliosarcoma, and he is years and doing fine. So it doesn't mean that it's automatically going to be a bad outcome. Not at all.
Okay, thank you for that. A couple more questions about Optune. So tumor treating fields, also known as Optune. Have you heard when Optune may become available in Canada outside of clinical trials? It was approved in November 2022. And a follow-up question by somebody else was, can the Optune be used in recurrence? And my understanding is that it's indicated for recurrent.
Yeah. So the answer is that it's there. The company is going back to Health Canada and trying to have it. One of the questions is can this device be treated like a drug? Because there are clear pathways for drugs to be accepted, but this is the first time we've seen a device actually have benefit, and there's a longer process to get it accepted, and there's a lot of controversies going on in the background. But that question is being debated now, so I can't tell you, but I do believe that I'm very confident by the end of the year this will be approved, because I think the data are very compelling. The original trial was done in newly diagnosed patients, and I was one of the investigators. I'm one of the authors on that paper. It's an excellent trial. It's used in recurrence, but the best data is in the newly diagnosed setting.
Okay, perfect. Thank you. Can you inject the drug into the CSF?
That's a fascinating question. So the CSF, cerebrospinal fluid, is the fluid that bathes the brain and bathes the spinal cord, and it flows through sort of these portals, or what we call ventricles. And if you may recall, in the MRI scan that I showed a picture of the ventricles, and so that has been tried to inject chemo into the CSF because you're getting it bathed. It's the fluid is flowing through the brain, except that what we have found is that when we inject the drugs into the CSF, the penetration into the brain is not more than 5 millimeters. Okay. Almost, usually less. So it's just not able to penetrate far enough into the brain to have any benefit. Some have tried to inject chemo right into the tumor, or after surgery, right into the surgical bed. Same thing. And it comes down to this barrier that we're talking about. It just prevents things from getting into the brain. It's such a powerful wall.
Okay, thank you. You mentioned how blood vessels feed the tumor and the tumor needs blood to survive. Just curious if there's been research into cutting off the blood supply to the tumor. I'm sure it is not this simple, just curious. Thank you.
No, this is, so as a matter of fact, there is a profound amount of research asking that question, because there's a drug, for example, bevacizumab, or also known as Avastin. Some of you may have heard of it. It is a drug that starves tumors of their blood supply, intravenous, given every 2 weeks, not funded by most of the provinces in Canada. You can get it in BC. I think you can get it still in Newfoundland. And I think that's it, where it's funded. Patients can pay for this drug. It is, at least in Alberta, $100,000 a year. And there is no survival benefit. Where it seems to be very effective is in decreasing symptoms. It can change the appearance of the MRI. And originally, when we were giving this drug, we would get faked out because the MRI scan looked better. But what we found was that it was just a change in the appearance of the MRI and not necessarily profound benefit. Some patients get an incredible benefit with it symptomatically. Some patients can even have some tumor shrinkage, but there is no data that it improves survival. The randomized phase 3 trials have all failed. So it's accessible in some places in Canada, covered, but in the vast majority of the country, it's not.
Perfect. Okay, thank you. We have a lot of questions that have come through, so I just want to pause for a second, just let everybody know that we'll take questions up until 2 p.m. And then Dr. Easaw, maybe you and I can do an extra little video answering
Yeah, sure.
other questions sometime.
Yeah,
in the
that'd be
next.
awesome. That'd be
Okay,
great.
that'd be great. So this question is about Gliolan. Is that the wafer?
Oh, yes. Yeah.
So
Yeah.
I work at a center that is trialing the use or trying the use of Gliolan to aid in better resection. Do you think that this will change treatment after surgical resection if Gliolan is standardized?
So Gliolan, so the
I
name
haven't
of the
heard that.
wafer is
I haven't heard that in a while, actually. Gliolan.
right. So like there's the wafers are actually called Gliadel
Okay.
wafers. So can you, is it Gliolan? Did I mishear you?
And it was typed out as Gliolan. So maybe if the person is still on the line, maybe they can add the question again, or maybe just to clarify for us.
So if you were to take that question, sort of expand that, there's something called 5-ALA, which can help illuminate the tumors intraoperatively. And our surgeons are using that here, and that helps them with their resections. So maybe that's another term for 5-ALA, but the wafers were called Gliadel wafers. They're not used. They're expensive, and the benefit is questionable. So not used anywhere in Canada as far as I'm aware, unless this is and this may be a new thing, and maybe it's part of a clinical trial.
Okay.
The Gliolan.
Okay, we'll see if a question pops back up. This question is about survival statistics. What does month 0 represent? Diagnosis, question mark, or end of treatment cycle?
Time 0 is the day of surgery.
Okay.
Time 0, everything starts from the day of surgery because we can always go back, and that's a fixed day. Time 0, and then we go from there.
Okay. Is there anything new with surgery on glioblastoma on either initial or recurrence?
Yeah. The newest, well, the two new things are, one, this 5-ALA, and the second is intraoperative MRI scans. So many, not all, neurosurgical services have an MRI scanner in the operating room. Okay. So they can do an operation, stop the operation, do an MRI scan, and see what is left over. Is there anything more they can get after? Then they'll go back and put the patient back on the table and continue their operation. And for us in Edmonton, this has definitely increased the extent of operation of surgical resection, which is what we want. The more tumor that can be removed, there's less that the chemo and the radiation have to go after and try and get rid of. So we're strong advocates of maximally safe surgeries.
And I will mention that Dr. John St. Clair from Ottawa will be giving a presentation on ALA and surgeries in general towards the end of the year. And he also gave a presentation on the topic a couple of years ago, but he's going to give an update this year through our webinar series. So just a note for everybody, just to watch out for that. Would you kindly explain whether the post-treatment changes and actual progression of a resected GBM would be mistaken for one another? And how long would it be enough to distinguish between them?
Right. So this has been an important question in our field. So, so the question is talking about someone gets an operation, gets radiation and chemo, and we used to do the first MRI scan 6 weeks after the radiation was done. And what would happen is that we would look at the MRI scan, and it would look like the cancer was growing.
Right.
But we published a paper that showed that 50% of patients, 50.0% of patients actually were not progressing. It was just swelling from the radiation. And we were getting faked out thinking this was progression when it was actually just swelling. And if we had just waited a little longer, that swelling would get better. And so that swelling is called pseudo progression. And so now the Canadian standard, based on our data, but not only that, I think it's pretty much accepted across the world, that the first MRI scan is done 3 months after the completion of radiation to give more time for that swelling to go down. Okay. So I think that's what that question was getting after. Pseudo progression.
Another question is, do you have any advice for individuals beginning their careers in glioblastoma research?
Oh man, I think that this is an incredible area to do research. The need, I mean, the need is there, and we're just waiting for that next breakthrough. Somebody has to figure out how we deal with the blood-brain barrier and all the specifics about this cancer, but it's going to happen. It's just a matter of time. Boy, if somebody's interested in research. I mean, I know the Brain Tumor Foundation does a great job in providing fellowships for research and research grants. And I mean, I think the BTFC has to be applauded for a lot of these advances, including what I published of my own, comes from support directly from the BTFC. So definitely strong advocate. Please get into research in this field.
Absolutely. And I'll just expand on what Dr. Easaw said about our research program. So if you check out the research section on our website, we have $25,000 grants right up to $100,000 grants, depending on the type of research that you're doing. But if you want to learn more in more detail, we can connect you with my colleague, Sue, who can give you all the details on the different types of research grants that you can apply to here in Canada. So thank you for that question. Another question is, my husband has a grade 4 glioblastoma and just finished concurrent radiation and chemo last week and was part of a targeted radiation trial at Sunnybrook in Toronto. Are the trials for immunotherapy you mentioned available post-treatment? Do you know?
So the trial that I was talking about with TTF and immunotherapy hasn't even opened in Canada yet. To my knowledge, unless there's a local trial, there are no national trials looking at immunotherapy in Canada yet. So the answer to the question would be no. I don't think that there's anything with regards to immunotherapy yet for the particular setting that your husband is in.
Okay. Sorry, what was the last part?
For the particular setting that the patient's husband was in.
Okay, perfect. Thank you. I know that this is a hot topic, and I know that there's a lot of different information around cell phones out there, but the question is, what is the relationship between the extensive use of cell phones, especially the older ones from 25 years ago, and any relations to glioblastoma, any research in that area? There's a lot of, I mean, I think you and I could talk about this topic for hours.
So the WHO has identified cell phone radiation as a carcinogen. So the data are sufficiently strong enough for the World Health Organization to identify it as such. Some of the worst tumors that I've ever seen have been in people who have been on their phone all the time, like, you know, on their phone in the car, and it's a right temporal lesion that's aggressive. Do I believe it? Yes, I do. Is there a way to study this? No, not easily, because dose varies. The amount of cell phone time that I use varies compared to you, and it's very difficult to study. Personally, I believe that I personally believe the risk is higher in young people with thinner skulls, and so I'm not a fan of cell phone use in kids personally. I'm fine with texting and doing all the other things that they do, and most kids don't use the phone anyway. Most of them just text, so it's usually not a big deal. But what you're getting is my own personal opinion. I do believe that there is something there, that some people are vulnerable. The problem is we don't know who, and we don't know what the dose, meaning how much cell phone use is bad.
Yeah, I'll just add on to that we do have some information on our website around when the World Health Organization years ago did kind of classify it as a possible carcinogenic. We added information to our website. And that information does come from the World Health Organization around just some tips and suggestions of your own cell phone use, because like Dr. Easaw say, we would need long-term studies on this and it would be difficult to study. I will mention that in Europe, they kind of banned the use of cell phones of kids up to the ear under the age of 18 or 22, because hopefully I'm not misspeaking, Dr. Easaw, our brains, our skulls don't fully develop until that age.
Correct.
So the thickness
Correct.
of the skull, so to speak. I wonder if that's where that term comes from, thick skull. It isn't fully grown, I guess, until early 20s, right? And so they do suggest using cell phones as much as possible through text or speakerphone, or using earbuds as best as possible.
Actually, let me speak to that. So just with regards to earbuds, That's Bluetooth, and Bluetooth is essentially a radio wave. So
Right.
like we've had radio waves, radio for hundreds of years. It's not considered something that we are overtly worried about. So yeah, to your point, you know, the earpiece, not a problem, or their earbuds,
Yeah,
it's
yeah.
fine.
They say just to keep the cell phone away from your brain as much as possible, for especially for long periods of time, right? So if you're on the phone for a long time, just using kind of that speakerphone or your earbuds, for sure. Okay, thank you. We'll move on from that topic because I think, like you and I said, we could talk about that for hours. Next question. We'll take two more questions, and then, as I said, there have been, I think, almost 50 questions that have come through, which is the most Q&A. So I definitely think you and I can maybe do a recording of the rest of the Q&A at some point sooner than later. But next question is, my husband, 49 years old, was diagnosed with GBM stage 4 in December 2022. We were told it's too advanced for surgery and radiation, but he's currently stable after three rounds of temozolomide. He has the marker that indicates his tumor is responsive to temozolomide.
Right on.
Aware of any clinical trials he might be eligible for, or any other treatment options we should be looking at that might buy him more time? Now, that's a tough question to answer right now.
Yeah. So, I mean, I'm always reluctant to say that TTF is a possibility, and you can go to the US and get that. One of the reasons why TTF was rejected initially when the data was initially published in 2017 is that the cost was 20,000 US per month. Like, that's just not doable by anybody. But some have tried, and there's centers in the US that will happily do that. There is no compassionate access right now. We just tried to get some, and for a few of our patients, and we couldn't. So that would be one. The second would be clinical trial options. Now the problem is that your husband is probably not going to be eligible for a lot of clinical trials because the clinical trials presuppose that patients are going to get the surgery and radiation and chemo. And so this is a very unique and difficult situation. And without having looked at the MRI scans, if surgery can't be done, then the tumor is probably in a location that is high risk. And so that's another thing that could be in the way of participating in a clinical trial.
Yeah.
I think the only other thing I would recommend is, if you have financial means, is to consider bevacizumab, because depending on where you are, it'll have to be paid. Yeah, Avastin, but that would have to be, certainly in Alberta, that would have to be a drug that would have to be paid for.
Okay. We could, in our follow-up email with the replay, maybe include some information about clinical trials here in Canada. I know there's some websites that people can go to and type in the type of tumor they have and geographic location to see if there's anything in your area, but also speaking to your physician or your loved one's physician is really important as well about what clinical trials you might be eligible for, right? I think that's a kind of good starting point, eh? One last question. Since GBM is highly vascularized, would an interventional angiographic technique be possible?
Maybe. That's a great idea. That's an amazing idea, actually. Operationalizing that might be difficult, but because of the blood-brain barrier. So you can still inject a drug into the arm, for example, or something like that, and it still has to make its way to the brain and then through the blood-brain barrier. So it would still have that challenge. And there's no way to give sufficient blood or give sufficient drug past the blood-brain barrier, because the blood-brain barrier is everywhere. Wherever there's a blood vessel, there's a blood-brain barrier. Amazing idea. But it's not, there's nothing going on that I'm aware of right now.
Okay. Thank you so much, Dr. Easaw. Like I said, everybody, I know we didn't get to everybody's questions. I will follow up with Dr. Easaw. I will go through the questions that we didn't get to, and then he and I will record a private conversation Q&A, and we will send it out to everybody who has registered. I just need a couple minutes to do a few announcements and the door prize for everybody who has stayed on. But thank you so much, Dr. Easaw. As always, a wealth of information, and as I said, you just always present information in a way that's really easy to understand. And we really appreciate you and everything that you do for the people affected by a brain tumor in Edmonton and as well as across Canada. So thank you for joining us today. Really
Thank you very
appreciate it.
much. Thank
Yeah.
you. Thank you, everyone. Bye.
Thanks, everyone. So does everybody else stay on the line for me for 1 second?